listings in the thoracolumbar, PR, PL, or P. The difficulty comes in because of the transitional area, and that is because of the change in the angle of the facets, so we have to change our LOCs accordingly. So what we'll do is we'll start at the back. Remember I said yesterday, if you remember, when you start from behind, up to and including the anticlinal, and because it's the anticlinal that's your key to everything in adjusting the thoracolumbar spine. So I'll start with P listings. We'll work through all the P listings, and we'll do PR, PL. So if we start it back with a P listing, that means it's straight posterior, correct? So your LOC, you're going to use your inferior hand as your contact hand. Your segmental contact point is the spinous process, and since it's a P listing, your LOC is straight P to A. Right, so it's going to be pretty much straight to the ground. So you can see how he comes up, Dr. Jim comes up high enough where his episternal notch is right over his contact hands. He's going to thrust straight down. And he's going to do that same thing all the way up to and including the anticlinal, which is, remember what it is? 15, correct, T15 in the horse. Okay, now, once we get to T14, that's where the transition starts, and we said that it transitions over 3 segments, so it'll be 14, 13, and 12 is a transitional area. So on the P listing now, because the facets are changing their orientation, he's got to adapt his LOC accordingly. So at 15, he's straight up and down. When he moves up to 14, he's going to start to angle back a little bit. 13, he's going to angle a little more. 12, he's going to angle a little bit more. Now, sorry, I don't have numbers on that. So, like we said yesterday, if it's 90 degrees and you end up at 45, there's 45 degrees in there. Over 3 is 15. So don't worry about the math. Just remember that you've got to start adapting your angle to compensate for that. Okay, so that's the transitional area, T12, 13, 14, P. Now once he moves up to T11, now he's going to be at a 45-degree angle because now the facets are more coronal. Okay? So he's going to keep that 45-degree angle all the way up the spine as far as the top of the withers, which is T3. Remember, 3 is the first most easily palpable. So from 11 to 3, consider the upper thoracics. There'll be a 45 degrees all the way up. Okay. Any questions on posterior listings? Okay. Just because he's back there, I'm just going to touch on it real briefly again. We also mentioned the intertransverse because it technically is part of the lumbar spine, although it's really more part of the sacropelvic complex. But because it is part of the lumbar spine, we also mention it in the lumbar thoracolumbar region. So he's going to just adjust that straight down with his inferior hand on the intertransverse joint. And the important thing about that is that little downward rocking motion with his fingers at the end of the adjustment. You guys should all be good with those. Hopefully you've adjusted those by now, since we're several months down the road. Any questions on the intertransverse? So the other 2 listings in thoracolumbar are PR, PL. So we could make him walk all the way around, but we ride together, so I want to be nice to him this morning. So we're going to make believe that these are PLs. Okay, spinous left, PL. So you want to stand on the side of the left spinous laterality. With the P listings, although he was standing on that side, he could have just as easily been on this side, right? Yes, as long as he uses his inferior hand. Okay, now on these would be PL, so you want to stand on the side of spinous process laterality. And the angulation this time is, instead of being straight up and down for a P, you want to be just 5 to 10 degrees off the midline. And remember, two-handed, we aim from the LOC.
Your segmental contact point is?
Segmental contact point is the dorsal tip of the spinous process.
And since you do have an angle, even though it's 5 to 10 degrees, you will be in a fencer stance, as opposed to a straight. If you're doing straight P to A, you can have a square stance. But if you've got any kind of angle at all, then you've got to be in a fencer stance. I'm not going to move the bail, but I'm technically in a fencer stance.
And you guys remember that we always say, if you just look at my feet, that is not a fencer stance. That obviously is, but that is too. Okay, it's just how wide you open the fencer stance. And the reason reason for that, again, it just gives more stability. Okay, so we're gonna keep the 5 to 10 degrees as we progress up the spine. How far? Up to and including the anticlinal, right? So from the last lumbar all the way up to T15, we're 5 to 10 degrees off the spine. Now, T14, and with the P listings, we started to change. Same way here. We're gonna have to change our LOC because we're in that transitional area. The facets are changing from sagittal to coronal. So he's at 14, he's gonna drop down a little. 13, he's gonna drop down a little more. And then 12, he's gonna drop down a little more. And we ultimately wanna end up with those 3 segments as you transition down. We ultimately will end up at T11, where the LOC now is all lateral to medial, because again, the facets now are all coronal. We've done transitioning, they're all coronal. And the same way from T11 all the way up the withers to T3, your LOCs are all straight lateral to medial. Now, what also, there's 2 other things that happen in the upper thoracic region that are important. What's the first one? Yeah, the first one is he needs to switch hands now. Okay, so everything from T11 forward, you're going to use your superior hand. From T12 caudal, you want to use your inferior hand. I think if the notes say either one, you can use either one, 12, 13, and 14. But we'll try to make it easy for you as we go along. We'll try to make it easier. So everything from 12 back, if you want to use the inferior hand, that's probably preferred. 11 forward, superior hand. Why? Because the spinous processes have an angulation, right? And you don't want to cover up more than one spinous process. So the first important thing is switch hands, superior hand now for your contact hand. What's the other important thing? Stabilization, exactly. So what do we want to do? We want to have someone stabilize on either side of the contact. And remember, we said you got to tell them what to do. You can't just say, "Would you stabilize over there for me, please?" Because they don't know what you want. So you have to explain to them, I want you to put one hand on one side, one hand on the other, come into a fencer stance, kick one leg back.
Keep your back flat. Back flat, back straight. Now don't arch your back.
If you noticed, you can see from the side, probably not from behind me, on my back, it stays pretty straight. Was it? Pretty good. Okay. Feels good. Okay. Okay, so those are 2 most important things about those upper thoracic. Superior hand, you have to have stabilization. And we said last night in the lecture that the reason that we have the stabilizing person drop their head is because if you don't, when they thrust across, it's going to throw the person's head back, and you don't want to whiplash or hurt your stabilizing person. Any question about PRs, PLs? So I know it looks like a lot, but it's really not that complicated. We also talked about in the transitional region of the thoracic spine and the lower thoracic and the lumbars, there's 2 alternate contacts. And I just touch on them because they're not really preferred, but you can use them if you have to. Remember, in the transitional and lower thoracics, you can use a transverse process, where in the lumbar, it's a mammillary process. Remember how we said where they were located? If you just find the spinous process and come just off of it, in the thoracics you'll be on the transverse, and the lumbars will be on the mammillary. If you come out too far, especially in the lumbars, you're going to be on the transverse process. We don't want to use those because they're very thin. If you thrust over them, you can cause some damage, which we don't want to do. So in this case, the alternate contact is in the lumbar spine on a mammillary process. It's still the inferior hand, and your LOC is straight P to A. In this case, he's on the opposite side of the spinous laterality. Remember in lecture when Dr. G was the vertebra, how we showed how the spinous process and the mammillary on the opposite side would be perceived to be higher than the other. So it's the opposite side of the spinous laterality. And as you progress up, it's all pretty much the same. It's all P to A. Only when you get into the thoracics, now you're on the transverse process. You can use those if you'd like. Remember too that the transverses and the mammillaries are not directly across from the spinous process because of imbrication. So there is a little bit of a difference in there. Any questions on that?
Yeah.
Okay, yes, Joe.
Yeah, remember last year on the skeleton, when I showed you what the transverse processes and the mammillary processes, where they're located, interspinous space, cranium. Right down there in the interspinous space.
So basically, if you find the spinous process, go to the cranial edge of it and drop off. That's going to be the mammillary or transverse for that particular segment. Yeah.
You guys want to find T15? A real quick way to find T15. If you just stand back at the horse and just split the horse in half, you just stand here and go, okay, about half and half, and walk up to the horse and touch. That halfway point's T15. And I promise I'm not more than a segment off. So it makes you look a lot more confident than going, and trying to count those vertebrae. Just split them in half and put it there, and I promise you're not more than a segment off. So just split the horse in half, and that's where T15 should be.
It's the same as when you're trying to find C4. Atlas, the shoulder, halfway, C4.
Yeah, split him in half, yeah.
And C4 tends to show up a lot on exams. Not just here.
Oh, I know where it was. The question was asked yesterday about counting. What's the best way to count? The way I would count would probably be different from what you would. With what Dr. G just said for 15, if we, for example, gave you L1, I wouldn't start at the withers and count 3, 4, 5. I would probably start from the back or follow the last rib around or whatever it is. But we don't care where you count from. Okay, so while Jim is on the bell, we'll talk about posterior ribs. Remember, there was 2 different listings: posterior cranial and posterior caudal rib. So with a posterior cranial, remember that rib is somewhat stated that way. So you want to drive it anterior and caudal, right? So you want to use your superior hand. Your segmental contact point is actually on the angle, above the angle of the rib. We kind of call it the rib, the shelf. So if you come out, there's a shelf that sits right across there, you'll fall right on it. If you go too far, you just run out of rib. So your segmental contact is there. And the important thing in this, again, is there's a little rocking motion at the end to make that move caudally because it's posterior cranial, right? LOC is straight down with a little rocking motion at the end. Posterior caudal. The other one is posterior, that's posterior cranial. The other one is posterior caudal. So you'll switch hands this time because now it's posterior and caudal. I'm going to move it anterior and cranial. So you're going to switch hands, everything is the same. LOC is straight P to A, and the rocking motion at the end. We just follow your fingers down. Gives you the rocking motion. Everybody okay with posterior caudal and cranial ribs? So then we have an anterior or ventral rib. And we said, as far as belt safety, be careful when you jump off them. If you need help, I know. He hurt his knee yesterday, so he's a little out of sorts, but just be careful when you guys jump off them. And by all means, I hardly ever say never or always, but I will say never jump off the bale behind the horse. That's one time I will say never. So the anterior rib requires 2 people, and remember we said that the contact point. We'll have Dr. Jim point to the contact point. Okay, so you're going to use that. That's going to contact the anterior rib head. And we've interlocked and grasped forearms here. That's what it's going to look like underneath. Okay, so the other person's going to come around.
and you use your inferior hand because Kendall wouldn't be here, so hand me the. So I'm gonna hold the lead rope as the adjuster in my supporting hand, and then I find the rib that I need to adjust, and go ahead. No, you go, you finish.
So he's gonna find the rib, he's gonna adjust it, and instead, me as the assistant, I don't really do anything, I just hold. And the adjuster, the doctor is gonna use an LOC to move that anterior rib posterior, because it's anterior. So it's pretty much just gonna lift up.
And as the adjuster, I need to tell him a couple of things. Number one, if I tell you to let go, you let go immediately, okay? Because he's fixing a cow kick or something like that, all right? When you adjust that, if it's sore, a horse tends to rear up. So again, you want to let go soon after the adjustment, okay? Their idea is to get away from the pain, and in this situation, the only way is up, okay? So just really kind of watch yourself, watch the horse, and watch the guy that's helping you, okay?
Sometimes they'll grunt when you adjust them. I think in class too, somebody asked yesterday about indications or how do you know? Generally, I know I said yesterday about you will find them, but I think rarely will you find an anterior rib without having some type of posterior rib also. A lot of times, as just a screening mechanism, I'll just take my thumb, I'll run it down to look for PRs, PLs. Remember we said the longissimus was segmentally innervated. So a lot of times you'll get that
Paniculus. Paniculus.
Paniculus response. So if I just take my thumb and run it down the longissimus, I'm looking for some type of response, or I'm also feeling for an area that might be particularly tight or tender. I can do the same thing over the iliocostalis and just run my thumb down that way. And I'm jumping around. So for you guys over there, I'm just basically doing that on the longissimus and coming a little bit more lateral on the rib shelf and running my hand over the iliocostalis. And again, I'm looking for the paniculus response. Yeah, right? I have trouble with that word for some reason. It's an easy word. On the anterior ribs, it's more of a pressure challenge. You just kind of want to reach under and sort of press into those rib heads to see if you feel anything that's particularly tender or painful. Do you guys have any other way of finding those?
So is it just like a smooth lift, or you actually?
It's more of
Okay.
a,
It's pressed up?
yeah.
Okay.
Are you contacting on the rib head or on the rib body?
I think technically it's on the rib head, correct?
As close to the sternum as you can.
The head is a posterior, is up by the vertebra.
It's the,
Oh,
it's
okay.
the.
The head
costal sternal-
anatomically.
Costal sternal junction, or chondral.
Costo-chondral. Costo-sternal for here, costo-chondral for up here.
So you don't want to be on, remember the dogs that we had yesterday were really narrow chested, and there was only a very tiny space to get onto that rib area. Horses, usually there's a little bit more area. Just make sure you're off of the sternum. So as I mentioned, now let's talk about that next. Let's talk about the sternum. Remember in horses also, it's segmented, so there are sternobrae. It's not a solid fused sternum like ours is. And any one or all of those segments can also be subluxated. So you want to stand, if we were going to adjust the sternal segment, you want to stand on the opposite side because it's a pull. And you want to use your fingers to contact those sternal segments underneath. If you feel like it's the entire thing, you can spread your fingers out, or you can overlap them to adjust an individual segment, and it's a pull toward you. The other thing that's important about that is, if you don't stabilize, you're just going to pull the whole horse toward you. So you've got to get your chest up against the barrel of the horse. So you almost have to kind of lean into them to keep from pulling them over.
And try and drop your elbows as much as you can so you get as much of that lateral to medial. So you're going to be kind of down here like this, leaning up against him, and then it's going to be like this.
Questions on those? Okay. So while we're in this position, let's talk about the costo-chondral adjustment. going to stand on the same side using a supported thumb. The segmental contact point fits really nicely, kind of in that V trough there, so you're going to contact the costo-chondral junction. Your LOC is lateral to medial. Straight across. Do you guys find many of those? I don't really find those commonly. On the jumpers.
Horses with, have y'all heard of heave lines? Heave lines are horses that have COPD. They're going to have hypertrophy of the muscle structure right in through here, and that lays right on top of that costo-chondral junction, and those horses tend to have, just because of the aberrant respiratory movement that they have, can stress those joints.
When you find, just for my information, when you find those and you adjust them, do they seem to be particularly more painful than?
No more than a regular one would be. Anything's painful. That's fine.
Remember too, when we adjust ribs, I gave you guys that research article that talked about substance P, how it's released in those costovertebral articulations, and how substance P is related to inflammation and pain. I always think substance P, pain. It can stay there for a while even after you correct the subluxation. So they may remain sore for a few days, and I always tell my clients that. We adjusted some ribs today, they're probably going to be sore for a few days. So let's not put anybody on them for a couple days until that soreness goes away. Because you don't want to get right back on and ride and they're still painful, and they're going to, I still hurt, so what happened? The last one is the manubrium. Remember in us we have an external notch. They don't, they have kind of a pointy manubrium, and that can subluxate as well. So you want to be on the side of laterality, as it were. Use a supported thumb. Your LOC is going to be lateral to medial again. It's kind of small. Doesn't really take a lot of force to adjust. Any questions on those? You want to turn the horse around? Do you see it, or do you want head on? So that was the manubrium. So those are pretty much the adjustments in the thoracolumbar region. Anybody have any